So good morning, everyone.
Good morning, sir.
Uh, okay, thank you. So today I am Dr. Shrikant Londhe. Basically, I'm a neurointervention radiologist at Bharati Hospital and in charge of the neurointervention services. So today's topic is very important. So as you say in the title, there are two catchy words. So first word is the neuroendovascular therapy, and the second thing is the neurovascular diseases. Now this is a latest advance which has come in the management of the neurovascular diseases. So first of all, we'll see what is the meaning of the neurovascular diseases actually. So I would say broadly, if we are to classify, it deals with the blood vessels of the brain, basically. So blood vessels of the brain, we have arteries and we have veins. So acute ischemic stroke, this is the most common neurovascular disease. The second thing is something known as a brain aneurysms, which is nothing but the swelling of the blood vessels of the brain. Just a minute, just a minute. Okay, somebody has done that.
बाथरूम में पड़ी है.
So first thing is acute ischemic stroke. Second thing is a brain aneurysm, which is nothing but the swelling of the blood vessels of the brain. Third thing is a cerebral venous thrombosis. That is the thrombosis of the venous side of the brain. And the fourth thing is arteriovenous malformation. We'll see one by one. Now, what is the meaning of the neuroendovascular therapy? Basically, it is nothing but the same job cardiologist does it for the heart. So from the femoral artery in the leg, we go inside the blood vessels of the brain. Cardiologists, they go inside the blood vessels of the heart. And the neurointerventionist, we go inside the blood vessels of the brain.
ट्रीटमेंट है पैरालिसिस के पेशेंट के लिए.
So basically, we have three major treatments. The first treatment is nothing more known as the angioplasty or the stenting. Whenever there is a long-term blockages, we can do a angioplasty or the stenting. The second and very recent treatment is the thrombus removal or the clot removal from the blood vessels of the brain. And third thing is whenever there is a bleeding inside the brain, active bleeding, we can close that bleeding site. So grossly, these are the on three parameters of the treatment where we work actually to give the benefit of the treatment to the patient. So first we'll see the most common thing, that is a stroke. So we know that strokes are divided into two types. Stroke is basically occlusion of the blood vessels of the brain, that is ischemic stroke, or the blood vessels inside the brain has ruptured leading to the brain hemorrhage, that is the hemorrhagic stroke. So sudden onset, one side of the body, we know that it is a stroke, either an ischemic stroke or the hemorrhagic stroke. To identify the symptoms of the stroke, there is an acronym known as a BFAST, that is the loss of the balance, loss of the vision of the eye, sudden onset, facial deviation, arm or the leg weakness, and the speech difficulties can be an aphasia or the slurring of the speech. And time is very important in this. We'll come to know this later. So now what is this new treatment? For stroke, we know when the patient present in initial 4.5 hours, we know there is something known as an intravenous thrombolysis, like from the peripheral venous cannula, we can start a thrombolysis for the patient when patient present within initial 4.5 hours. Now what happened after that 4.5 hours? There is a new treatment which is known as a so that in initial 6 hours or 24 hours, if you remove this clot, we can save this part of the brain. This part of the brain we can't save because this is already dead. That is the irreversibly damaged. So the purpose of the treatment is to go into these blood vessels and remove this blood clot as early as possible to save this part of the brain so that recovery will be very fast in stroke patients. So that is the meaning of this, something known as a LVO, means large vessel occlusion. Now in stroke, we do something known as a CT scan to identify ischemic stroke or the hemorrhagic stroke. Along with that, we should always do CT angiography or MR angiography. What is angiography? Is a examination of the blood vessels. So only on angiography we'll come to know where are these blockages, because in brain we have multiple blood vessels. So ideal protocol for any acute ischemic stroke is CT brain with CT angiography or MRI brain with MR angiography. Always do angiogram. That is a take home point. So what is this new treatment now? So this is a small video actually. So inside the blood vessels of the brain, so from the femoral artery, we take these small tubes which are known as the catheters. And suppose this is the clot which is obstructing the blood flow of the brain. We cross that clot using something known as a micro wires or small wires. And on top of that wire, we place a micro catheter or the catheter. These are basically nothing but the tubes. Inside these catheters, there will be a stent. Now, purpose of the stent here is to not to open the blood vessel. Purpose of the stent is to capture the blood clot. So we keep that stent for 4 to 5 minutes. And once the clot is captured, the clot, stent as well as that tube, microcatheter, will be removed together as an assembly. So this is very important. Like unlike acute MI, we don't place a stent here. Our purpose is to remove the clot as early as possible. And this is the procedure which is known as a mechanical thrombectomy. This takes hardly 20 to 25 minutes, but for the patient, it will be life-saving. So now when to do mechanical thrombectomy? As I already said, it is indicated in first 6 hours in selected patient till 24 hours of the stroke. Now we have one treatment which is known as intravenous thrombolysis already. So why this new treatment? Because studies have shown that intravenous thrombolysis works only in 10 to 15% of the patient. The technical success rate of intravenous thrombolysis is only 10 to 15% of the stroke patients which are presented within initial 4.5 hours. Now, what is the technical success rate of mechanical thrombectomy? It is close to 90 to 95%. So there is a big difference between the efficacy of the procedure, and that's the reason mechanical thrombectomy in nowadays is a standard of care. Like there is no other option. Whenever acute stroke patient is there, we have done CT angiography or MR angiography. Whenever there is a thrombus in one of the larger blood vessel, mechanical thrombectomy is the standard of care. There is no other option. Otherwise, patient is going to deteriorate in 100% of the time. So CT angiography is mandatory for all ischemic stroke patient. As I already said, if the major blood vessel is occluded, mechanical thrombectomy is the only available treatment. If we don't do this, then there is a almost 90% chance that patient might deteriorate further or can result in death also in next few days. And we have to always remember that time is brain, and we have to respect the time when it comes to the management of acute stroke patient. Now, whenever we get a stroke patient, we can get in OPD also. Some patient they can reach to the OPD also. Some patient they can reach to the hospital emergencies. So first thing is identify an acute stroke, do a proper imaging, that is CT brain with CT angiogram or the MR brain with MR angiogram. If you have the facilities, start the intravenous thrombolysis. And if you don't have the facilities for the mechanical thrombectomy, send the patient to higher referral center for the mechanical thrombectomy. We have to remember that the benefit of mechanical thrombectomy is time dependent. So if the patient reaches to the hospital after 6 hours or maybe 24 hours, even though facilities are available, even though patients in Indian scenario, they are affordable, we can't do this treatment because benefits are not there even if we do the treatment. So I'll come to the first slide again. So this is something which I showed actually. The more you salvage this area, the higher the treatment benefit. As the time goes, this is a dynamic relationship basically. As the time goes, suppose it is 1 hour picture. If you image the brain after 2 hours of the stroke, this area will keep on increasing actually, the irreversible or the dead brain parenchyma. After 6 hours or 7 hours, what will happen is this entire area actually will expand to this area. So at that time, even if you open the blood vessel, there will not be benefit because the already whatever brain which used to get supply from this blood vessel is dead actually. So that is the reason that when it comes to stroke management, we should be very fast. Now I'll show you one case which we have done. So this is a 35 young male with the left-sided body weakness in 6 hours. So this patient, now we don't have the option of the intravenous thrombolysis because it has already crossed the window. So directly he was taken for the mechanical thrombectomy. This is the preoperative angiogram. This is the one of the main blood vessels supplying the blood. Now after this, actually we are not able to see any blood vessels. So this has to be like this, supplying the brain. We have placed the stent. These are the markers of the stent. And this is after opening of the blood vessel. Now we can see the entire extent of the blood vessel, which is supplying the brain. And this is actually the clot which has come with the stent. This is the stent. We place a stent, it opens the blood supply as well as it helps in capturing the clot. These small windows which we know as the cells, the function of these cells is to capture the clot in between their cells. And once the clot is captured, we pull the stent as well as clot all together. So the entire blood supply get restored within few minutes. Now, in India, actually, it is in doctor's hand that what outcome we want for the acute stroke patient. So this was our patient after mechanical thrombectomy. After 2 or 3 days, he got discharged. So he had a complete weakness, 0/5 power on this side. After discharge, actually, he came to the OPD after 7 days and he had a complete recovery. That the maximum part of the brain actually we could save. So he had a complete recovery. He was one of the factory workers, so he started the work after 1 week or 2 weeks of the rest. On other side, if we don't do mechanical thrombectomy, this patient actually land up in permanent weakness. Then the future problems of bedridden, dependency on everything, like you will be wheelchair bound or the bed bound. For the feeding, you need a tube. For all the care, bed sore management, infections, urinary tract infection, there will be catheter. Along with the long-term weakness actually result in the spasticity. So the cost of this rehabilitation is very high in India. That we have to understand. It is not about the we have not done the treatment because of the lack of money. Actually, the cost of all this rehabilitation after the acute stroke management is almost 10 times of the cost of this treatment. So as a doctor, I think we should decide what choice we want for our patient, because unfortunately in India, actually patient, they don't decide and they leave it to the medical practitioner that what is the best choice for the our patient. So it is our moral duty. We have to decide between these two options. And now mechanical thrombectomy is a standard of care in 2021. So I have told about the acute stroke management. Then we have something known as a minor stroke, that the patient doesn't have any large vessel occlusion, but one of the very small blood vessel is occluded or the thrombos, and very small area of the brain was damaged. Clinically also patient was not having any major symptoms, maybe a mild slurring of the speech or the difficulty in speech, tingling or the numbness in the hand or the foot. So that is the only symptoms. In those patients also we should do the angiographic examination. See, stroke is a neurovascular disease, so we have to examine the blood vessels, and that is a mandatory. Sometimes what we get is something known as a carotid stenosis. What is a carotid stenosis? It is the atherosclerotic or the cholesterol plaque deposition, which is leading to the obstruction of the blood flow to the carotid brain blood vessels. So brain is not getting enough blood supply. For such patient, actually, we have something known as a carotid artery stenting, like an coronary stenting. So we place a stent, we open that blockages, so patient will not have any decreased blood supply to the brain. So this is one case we have done in the Bharati Hospital, and this is the carotid stent actually. This will be placed in the neck. So and this is the image after the stenting. Now we'll come to the second pathology, which is something known as a brain aneurysms. So what is aneurysm? Basically, aneurysm is nothing but the weakness of the wall of the blood vessel. So initially, when any person has sustained hypertension or in congenital abnormality where the wall of the blood vessel is weak, initially there will be small ballooning. Over the period of the years and years, the ballooning will keep on increasing actually. And at one point, when the blood pressure is not controlled or any other emotional or the physiological stress, there will be leakage from this point and the bleeding will happen inside the brain. Now, this is a what we call is a highly morbid or disease, highly complicated disease. The reason is one third of the patient actually they die at home. The reason is the blood flow is directly communicated to the aneurysm, and whenever there is a leakage, there will be massive blood loss inside the brain, and the sudden rise in intracranial pressure will be there. So 30% of the patient they die at home. 30% of the patient, whenever they present with the rupture of the aneurysm, they will be in the comatose stage. So what we get actually a good patient is something only 30% of the population where bleeding will be minimal. Once the bleeding happens, there will be a thrombus formation outside, and that thrombus actually partially covers the bleeding site. But re-rupture can happen, and the mortality of re-rupture is close to 90%. So we have to treat this as a medical emergency. That detection of the aneurysm and the treatment is a something medical emergency. We have to do it in initial 1 or 2 days. So what are the symptoms? Patient will present with again similar sudden onset severe headache, might have a neck pain with vomiting, signs of the raised ICP. So traditionally what we do CT angiography or the cerebral angiogram. And once we detect this aneurysm, we have two treatment options. So one is the open surgery where they will remove the part of the skull. They will remove they will retract the part of the brain. They will reach to the site of the aneurysm and they will place something known as a clip. So once you place a clip, so what is the purpose of treatment is we should avoid any blood flow inside the aneurysm. Whenever blood comes, there will be increased pressure, there will be re-rupture. So we place a clip here so that there will not be any blood flow inside the aneurysm. Blood should get directed towards the normal blood vessel. That is the purpose of the treatment. Now, since 1990, this new treatment has come. Like from femoral arteries, we can go to the brain blood vessels, and inside the brain blood vessels, we go enter inside the aneurysm without opening the skull or anything else, and we can place something known as a coils. These are actually a titanium-based coils. The purpose of these coils is to promote the formation of the thrombus in a such a way that thrombus will form only inside the aneurysm. It will not go into the normal brain circulation. That will be actually an artificial thrombus. So it will be a stable thrombus in comparison to the thrombus which is formed in the naturally in cases of acute stroke or the MI. So this will be an organized thrombus which will not result in any distal thromboembolism. Once the thrombus is formed, automatically blood will not enter into this part. So that is a treatment which is known as a endovascular coiling, and now this has become a standard of care because this is minimally invasive. You need not do any major surgery. There is no risk of long-term hospital stay and all those things. So this is one case we have done. This is the angiogram. We can see the swelling of the blood vessels of the brain, and they will rupture from the any point actually. So this is the swelling of the blood vessels of the brain known as an aneurysm. We place small tube inside, and these are the multiple coils after placement of the coils inside the aneurysm. And this is after the completion of the post coiling that we have done the angiogram to check where there is any blood flow which is going inside the aneurysm. There is no blood which is entering inside the aneurysm. It's totally cured, and this is the coil mass inside the aneurysm sac. So this is something known as another case, angiogram of the blood vessels of the brain, the swelling of the blood vessels of the brain. We enter with the small tubes which are known as a catheter. Through this catheter, we'll place multiple coils. This is the coil mass, and this is the angiogram after treatment. Only the normal blood vessels are filling, not the aneurysm sac. So this is known as a endovascular coiling. Now this has become a standard of care in the management of the aneurysm because this is a minimally invasive, and the treatment efficacy is same as a surgical clipping. Now we'll come to the third treatment aspect, that is the one of the most common after COVID pandemic, that is a CVST, cerebral venous sinus thrombosis. So from the arterial thrombosis, now it is a venous thrombosis of the brain. So this gentleman had a sudden onset headache, seizures and all, and this bright spot is nothing but the hemorrhage in the brain. What was the etiology for hemorrhage? Actually was a venous thrombosis. So we have done the CT scan, the thrombus in the venous side, it is seen. So this patient, the standard of care is a anticoagulation, that is the injection clexane, warfarin and everything. But some patient, they don't respond to this. In those patients, what we can do something known as a, again, mechanical thrombectomy. So we have done the angiogram. We can see that this part of the venous structure is not seen at all. This should be seen like this, continuity, but it was not seen. So we have done the same tubes we have taken in, we have placed a stent, we have removed the clot, and this is after removal of the clot. Now you can see the entire extent of the that venous sinuses. So this is also a treatment, but only when the patient doesn't respond to the systemic anticoagulation, they actually have worsening after starting systemic anticoagulation. And now we'll come to the fourth treatment, which is known as the AVM, or the arteriovenous malformation. So what is arteriovenous malformation? Normally what we have arteries. After that, we have a capillaries, and from the capillaries, we have something known as a veins. So arterial pressure is really high. The pressure get redistributed actually at the capillary level, and the venous side pressure is close to our CVP, that is a 0 to 10. Arterial side blood pressure is close to our blood pressure, that is 120 by 80. So this redistribution of the pressure happens at the capillaries level, or the smaller blood vessels like arterial or the venous. What is arteriovenous malformation? In simple term, it means that capillary formation is not there. This is replaced by direct communication between artery to vein, that is artery to venous malformation. So picture will be something like this, where we have a direct communication of the arteries to the veins, and it represents a tangle of blood vessels. So what happens here? Why this is a problem? The problem is because now high blood pressure is directly exposed to the venous side, and veins are actually not meant to sustain this high blood pressure. So they will give away. So they will rupture actually. And once they rupture, it will result in the brain hemorrhage. This also carries a significant high mortality. So how to treat this? Like the same way from the femoral artery, we enter into this abnormal blood vessel. So we know what is our target. We do angiogram, we define this is our target. And this all abnormal communication we can close actually. I have told already, neuroendovascular therapy is nothing but placing a stent in blocked blood vessel, removal of the clot, and third treatment is the whenever there is a bleeding, we have to seal that spot. So how to seal that spot? We place a tubes and we inject some material inside this blood vessel so that permanently this will get occluded. This is known as an embolization. So this is one case. This is the angiogram, and we can see multiple blood vessels with tangle of pool of blood vessels here. So we enter into one of these blood vessels and inject a material, that is embolization. This is the permanent material, and this is after injection of the material. We are not able to see that any of the blood vessels actually. And now this patient is cured. So cerebral AVM, we have something known as an endovascular embolization. Now another vascular malformation type of picture I will show. This kid actually had a social stigma because from the birth itself he had this swelling. It keeps on increasing, and at one point actually he started to feeling so awkward, so embarrassed that he left the school actually, and he came for the treatment. We have done the MRI. Now we can see there is a large pouch here. This pouch is nothing but the collected blood, nothing but the venous malformation. So the collection of the abnormal veins in this area. What is the treatment for this? We place multiple small needles and we inject something known as a sclerosant. Once the sclerosant comes in contact with this thing, it will shrink its size. So this is the MRI before the treatment, and this is the MRI after 3 months of the treatment. So we can see that now the pouch is totally gone actually, very minimal residues are there. And external swelling also will disappear so that he can resume to his normal life, whatever is there. So this is known as a management of the vascular malformation. The treatment is injection sclerotherapy. So to summarize, whatever neurovascular diseases I have discussed with you people, it is actually a separate subspecialty, mainly under the neurosurgery. And the new treatment, like in comparison to the open brain surgery, is something known as a neuroendovascular therapy. Is the most recent minimal invasive way to approach these difficult diseases, like I have told, acute ischemic stroke, brain aneurysms, brain artery venous malformation, and the venous thrombosis. And early treatment is the key for successful outcome. Like we have seen in the stroke cases, we have seen in the aneurysm cases or the venous thrombosis. Whenever patient condition is very bad, that is not the ideal time to intervene. Actually, the earlier the treatment, best outcomes. So this we have to remember. And I always believe that to build a center of excellence, what we need is a talent. Along with talent, the most important things are the teamwork. At our hospital, we work closely with the neurologist, neurosurgeon as the neurointervention services to have a better treatment outcome. And technology, this is the most important and confusing statement also. To do this neuroendovascular therapy, we need something known as a neurocath lab. So all these procedures will be done under fluoroscopic guidance. So we have something known as a cardiac cath lab, and the other thing is a neurocath lab. So to do this procedure, we need a neurocath lab, not the cardiac cath lab. And Bharati Hospital is one of the hospital in Pune where the dedicated cath lab is available for the neurovascular procedures. And that is the reason the outcomes will be much better in comparison to the procedure done in the cardiac cath lab. So all these three things together build a center of excellence, and I truly believe in this. Thank you very much.